Today what I'm going to talk about is our evolving experience with brain perfusion imaging and our attempts at exploring what I have kind of playfully named the revascularization penumbra. No, disclosures, personal ones anyway, but I think that in this field we should recognize that all clot retrievers are currently FDA approved for clot extraction, but they're off-label for stroke. IA thrombolytics are FDA approved, or not FDA approved, although pro-urokinase had a single trial, but it never had a repeat trial. IVTPA is FDA approved up to 3 hours, but not FDA approved between 3 and 4.5, and it's off-label. And the brain perfusion imaging topics we're talking about are investigational. Basic background, many of you I think are very familiar with this concept, but just to review, the concept is that when there is an acute blockage of a brain artery, the brain undergoes a process of ischemia, which over time results in infarct core. And the longer the ischemia, the more severe it is, the faster it becomes progressing to infarct core. There is an area around that core, which is what we have entitled or termed the penumbra, that represents tissue that is at risk that may survive if some type of intervention is performed, whether it's direct revascularization or a whole host of other types of interventions we could talk about. And that's called the penumbra. And then there's the area beyond that, which is the benign oligemia, the area of the brain that, even though is hypoperfused, will still survive without any kind of intervention. Brain that will manage with that lower blood flow state. The goals for ischemic stroke, acute ischemic stroke, of course, are to maintain medical stability, reverse the conditions that precipitated the stroke, which may be quite variable, unravel the pathophysiologic and anatomic basis of how that patient develops strokes, and try to assess the risks and benefits of therapy, not just thrombolytic, but all types of therapy, including surgical, interventional, and medical. What are our current guidelines? Well, we do have good evidence that with the NINDS 1 and 2 trials, that within 3 hours of symptom onset, if select patients receive IVTPA, they can have significant benefit. And I think that is the standard of care around the country and probably in many places in the world that can provide those resources. And so that is currently the only accepted therapy that we have that is standardized. There have been efforts to extend that therapeutic window beyond 3 hours because, as you can imagine, very few patients show up within that 3-hour window, and it would be ideal to be able to extend that window if we can, and that remains a big question. ECAS-3 was a trial that looked at the use of RTPA up to 4.5 hours and did show some benefit in a very small select group of patients. Endovascular revascular therapy, IA therapy, lots of trials, single-armed phase 1 and phase 2 trials looking at clot extractors that demonstrated some early efficacy at revascularization, although efficacy for patient benefit remained untested. PROACT-2 was the only trial that did have a controlled randomized design that did show benefit for intra-arterial thrombolytics up to 6 hours, which was promising over patients that did not receive thrombolytics with large MCA M1 occlusions. Now, one of the big questions is, how do we select patients for treatment? Can we do this independent of time windows? How do we know which patients are going to benefit, which ones aren't? And it's a multivariate equation, as we would expect. There is time, there's collateral circulation, there's age, there's comorbidities, the degree and severity of occlusion. And so one of the ways that many investigators are looking at the brain are trying to identify the physiology of what's going on within the brain in individual patients. And there have been many studies, Darby and his colleagues have showed that even beyond certain traditional time windows, 6, 12, 18 hours, if you do study the brain with MR, perfusion, diffusion imaging, or SPECT, nuclear medicine imaging, CT perfusion imaging, there appears to be what we would hope would be potentially salvageable brain well beyond our current windows. Now, one of the purposes of imaging in stroke is to rapidly triage these patients and try to determine which patients may benefit and which may not benefit from any kind of intervention. And rapidly, CT has become kind of the triple modality of choice because of its wide availability, rapid application, and its ability to provide us with very valuable information, including the presence or absence of hemorrhage, aspect scoring to determine irreversibility of injury, perfusion imaging that can give us physiologic information, cerebral blood flow, cerebral blood volume, as well as CTA imaging, which can identify the site of occlusion, the nature of the occlusion very quickly. Once again, going back to the idea of trying to identify tissue that is already progressed to core or dead brain versus tissue that may be on its way to becoming core but still has the potential opportunity for reversibility. How does perfusion imaging work? Well, this is a very standard technique of an indicator dye dilution technique. In this illustration, courtesy of Professor Ewing from Henry Ford, who was kind enough to share this. And essentially, whether it's MR perfusion or CT perfusion imaging, what you're doing is you're injecting an indicator proximally, whether it's gadolinium or iodine, and then you're measuring it distally as it goes through the brain tissue and measuring transit time and area under the curve, cerebral blood volume, and you're getting an idea of the perfusion. Now, in terms of which imaging modality is better, or how do they compare? Well, CT and MR are comparable. One of the differences is that MRI uses gadolinium, which is more of a 0 or 1 signal characteristic. So it cannot give you absolute values. It does not have a gradation. Right? And so that's one of the limits of MR, is that it can only give you relative values of CBF and cerebral blood volume. CT does have the potential, because you're using X-ray and contrast, which has attenuation coefficients, the ability to potentially give us absolute values. And so that's kind of what we've been focusing on at Downstate and at Lincoln Hospital, the two places where I primarily kind of run our stroke programs. Concepts being in that when you obtain brain perfusion imaging, we will see certain patterns that may categorize brain tissue. If everything's normal, that's great, that's normal. If what we believe is that when the tissue becomes ischemic and the cerebral blood flow will drop, and as the autoregulatory mechanisms and compensatory mechanisms of the brain vasodilate collateral circulation, they also increase oxygen extraction fraction and decrease transit time, that there will be an increase in cerebral blood volume in ischemic tissue up to a certain point. And then when that brain is beyond its compensatory mechanisms, it dies, and then the autoregulatory mechanisms will cause that cerebral blood volume to precipitously drop as blood is now diverted to viable tissue and perhaps in an evolutionary protective mechanism diverted away from dead brain where reperfusion hemorrhage might occur. And this is kind of the traditional concept that's evolved over time, and I think many people believe that at some level this may be happening. Here's an example of a patient with an MCA occlusion, and here we can see that this is a large area on the left, MCA territory, which has a prolonged mean transit time with diminished cerebral blood flow, but normal cerebral blood volume. And so in this concept of penumbra, we believe that because the CBF is low and the CBV is normal, that this brain tissue has the potential to survive if some type of intervention is performed. Now, what are the results? What are some of the results that people have had and we've had? Professor Ueda and Bill Yu were some of my mentors back in Iowa who originally kind of pioneered this concept back before it gained more widespread acceptance. What they looked at was, and back then in the 90s, what they were using, because MR perfusion and CT perfusion weren't really readily available yet, they were still in their early nascency in terms of development. They were doing diffusion imaging and SPECT imaging in acute stroke patients. And they looked at 30 patients. And the key here, and this is one thing that we also have looked at in some of our research, is looking at patients that have been recanalized. I think that one of the problems with much of the studies that have been performed that have looked at perfusion imaging and whether or not it predicts penumbra versus infarct is that they're often in mixed populations where we don't know if we've restored blood flow. So unless you've restored blood flow, the concept of penumbra is somewhat elusive. And so what they did was they looked at recanalized patients, and they found that based on SPECT imaging, that there were certain thresholds that might predict reversible versus irreversible brain injury. And when they looked at the MRI imaging, they found that certain characteristics seemed to be more sensitive and some were more specific. And so if you look at the size of the final infarct on some of the reperfused patients, you can see that the ADC map, the diffusion imaging actually overestimated the infarct by a factor of almost 2, while what seemed to be the most specific for final infarct volume was the relative CVV that they had obtained. And so as a fellow with Professor Chalupka in Iowa, what we did was we used these concepts to aggressively screen patients beyond the traditional 6-hour window. We were using a combination of SPECT or MR perfusion as that technology started to become available, and diffusion imaging. So as you can imagine, it was kind of a challenge doing those patients, because you'd be running from the MR to the nuclear and then taking them up to the IA suite. And so some of our early experience, which I got lucky enough to present in Hawaii back 12 years ago, and I haven't been back since, and it'd be nice to go. But we did find some promising early results, and we used kind of a combination of IA therapies, using pharmacologic as well as mechanical, and it wasn't a systematic, kind of prospective study that we had done, which would have been ideal. But it was, what we did was, when we look back retrospectively, that there was a low incidence of hemorrhage in this prolonged therapeutic window if we carefully selected patients. So I think that this introduced the idea that there's opportunity beyond the traditional windows, but I think we have to be careful on who we pick. And so that's kind of where the early thoughts go. And so over the last 10 years, I've been at Downstate, and probably over the last 7, we've been kind of aggressively screening patients. Professor Anesti was, kind enough to recruit me to Downstate from Columbia, and I've had a good opportunity to work with a lot of great professors there. These are the students, medical students, Jen Tang and Brandon and Alan, who worked really hard on this. And what we did was we found 10 patients that we had complete data sets on. They underwent perfusion imaging, they underwent angio and intervention, and then we divided those 10 patients into patients that got revascularized near completely versus patients that did not get revascularized, that remained occluded. And so how we looked at this data set was that if you remained occluded, then anything that that survived essentially was benign oligemia. Because if you're occluded, you can study the benign oligemia to penumbra margin. But patients that get revascularized, anything that survived was penumbra plus benign oligemia. And so you really have to differentiate if you want to study the different margins of the penumbra. You cannot study the core penumbra margin if you have occluded patients. And so we divided that up. And so we had only 10 patients, but what we did was we co-registered their imaging. So you had the perfusion imaging, revascularized, and then 3 to 7 days later, you had their CT imaging or MR imaging, and you did this, the co-registrations and the subtractions, and you figured out which pixels survived and which pixels did not. And so we had, tens of thousands of pixels, and if you look here on the CBF survival curve, the blue here is the survival tissue, right? And this is the dead tissue. And these are the numbers, CBF here being about 25, where these lines cross. And this is in the persistently occluded group. So if you remained occluded, then above a CBF of 40, your tissue kind of survived. Below 40, you had trending down, right? So this seems to be areas where, okay, above 40, it's kind of benign oligemia in the occluded group. But if you revascularize the patients, right, then the curve shifted quite a bit. So now in the tissue that was revascularized, CBF, even at the lowest levels, we all had more than 50% of the tissue survive, suggesting that revascularization, can save quite a, save brain tissue, at least based on our perfusion data, right? That occluded versus revascularization does make a difference. At least that's what we think, or we hope. CBV didn't really tend to predict that as well in terms of, it didn't really differentiate, versus benign oligemia on the occluded group. But what was interesting on the revascularized group, and many of the numbers that have been thrown out there on some of these mixed series of perfusion imaging and IA therapy have suggested that CBV below 2.0, they've used that number 2.0 as a threshold, that says, oh, well, below 2.0, it's dead, don't worry about it, it ain't coming back. And that's also some of what these more recent prospective trials are kind of looking at. But when we looked at our revascularized group specifically, and look at the 2 number, we still had 70% of the brain tissue, pixel by pixel, survive at 2. And even at the lowest level of CBV, 0 to 1.5, we still had 50% or more of pixels survive. And this was within 12 hours. And so, the IA intervention happened within 12 hours of the event. And so even out to as far as 12 hours or 8 hours, 9 hours, we think that these cerebral blood volume thresholds are still, I think, unclear. And I think we need to study revascularized patients exclusively. And this is going to be kind of a common theme in terms of my thoughts. And so, with the mentorship of Professor Paul Spellman, who encouraged us to try to develop this program, an acute ischemic program at Lincoln Hospital in the South Bronx, what we did is we worked with a team of partners in the South Bronx at Lincoln Hospital and developed our acute stroke program there, where we categorized patients into certain windows of opportunity. In patients that were greater than 8 on their stroke scale score, and within 7 hours, we decided to screen aggressively with CTA and perfusion imaging, and then consider offering them potential interventional therapy in select patients. And so we started in August of 2009, and in our first year, we had 223 total strokes at that hospital, of which the category 3, the IA interventional candidates, were 63 activations, 50 ischemic, 13 hemorrhagic. I showed up 28 times. Of those 28 times I showed up that year, 12 patients we decided not to do anything because their CTA or perfusion was negative, or I think there might have been one that had large vessel occlusion but wasn't a good candidate for one reason or another, I can't remember. But you could see that if we didn't intervene based on that CTA perfusion triage, they did pretty good. Pre-ANIH stroke score of 11, post of 1, they're doing okay. So maybe we're doing a pretty good job of not doing anything on them. Of the 16 ones that we did intervene on, we had some improvement. Whether or not this is related to our intervention or not, that's something to debate. And I think that the MR rescue trial raised some questions. But at least it looked pretty good initially. And so back then we were kind of excited, oh, maybe we're helping. When we looked at our 28-month experience a little bit more recently, up through 2011, and you can see that of the 36 patients we did at Lincoln during that little over 2-year period, the pre-NIH stroke scale scores and the post-NIH stroke scale scores in terms of the ranges. This is not patient per patient, but just kind of a range. Looks like we're helping. I don't know if it's real or not, or if this is, it's not a controlled group. When I compared our discharge MRS scores, right? So we got 0, 1, 2, 3, 4, 5, 6, 6 being dead. And we looked at and compared it to some of the other trials, multi-mercy occluded versus multi-mercy revascularized. I think that's a very famous graph where we can see, that the 0 to 2 group, if you reopen them, it's a much bigger group. What, 20%, 42%, 44%. If you don't open them, it's only 10%, right? This is the multi-mercy data. IMS3 shows also very close to the multi-mercy revasc, when you look at it in this way. Our experience at Lincoln, we were a little bit more aggressive because we screened everybody with CTA. IMS3, had about half their patients that weren't screened with imaging, and so there were a lot of patients that probably had lacunar strokes or small vessel that were included in IMS3. So it's a different group. We're not really comparing apples and apples. But I think as in our limited 36 patients, I think we just as a benchmark, we're kind of trying to see how we're doing. Kind of like Professor Norbash is saying, kind of internal testing ourselves, seeing how are we comparing with our colleagues. Now getting into the IMS3, now I got the I don't know if it's a pleasant or unpleasant task to talk about IMS3 and MR rescue, but let's take a look at IMS3 and see, is it such a negative trial? Is it, and I think, it's not a positive trial, that's for sure. But overall, there does seem to be, slight trending towards, improved outcome with endovascular therapy over IVTPA alone. Not so much in the mild group, maybe a little bit more in the more severe group, but it's not statistically significant. There's some limitations to the trial, and I think that one of the big keys and this is kind of their subgroup analysis, and I think the thing that people have harped on the most about why it failed is speed. That seems to be what everybody feels is like, we're not fast enough. We're not fast enough. We need to be faster. And I think time is important. We know that from, I think that, if I can find it, right down here, it seemed to be that if you got there faster, you tended to get better results. And that makes sense, of course. I think that, the brain is dying the further time goes. But I think one of the bigger keys is revascularization, and I think and that's something that I feel has kind of gotten lost. So this is kind of a review of some of those basic, those trials. PROACT 2, median 17, stroke skill scores. They didn't really tell us how much they, revascularized in the control group because there was no angiograms. If you look at the PROACT 2, 40% good outcomes, and their revascularization, they used TIMI grading systems. Only 19% had TIMI 3, 47% had TIMI 2. And TIMI 2, hard to really, I think, figure out what that means in brain perfusion, but in terms. When you look at, ECAS and the IV stuff, in the control groups, obviously you don't get that revascularization. In the IMS3 group, right, which is the most recent study from, that published in the New England Journal, only 2% of their patients had TICI3 revascularization. Only 37% had, 2B revascularization, meaning that basically 60% of the patients got revascularized 50% or less, which I think is reflecting that our tools are not really revascularizing patients to the extent that may be necessary. Are we achieving the threshold of revascularization that we need? If you look down at multi-mercy, it was self-reported TIMI, 55%. There was no real differentiation of 3. The penumbra pivotal, also TIMI. These are trials, designed to get FDA approval, not designed to really, compare, do comparative science. But so 27 to 57%. The SWIFT, they did do core lab, which was interesting but they didn't really publish the TIMI 3 versus 2B, okay? And then Trevo 2 did TICI, so I think one of the keys, is that we're not really achieving complete revascularization. And so I think that we need better tools or better strategies to even assess whether or not, we are affecting or achieving, the maximum benefits of the revascularization penumbra. MR rescue, looking at perfusion imaging and diffusion imaging, showed really no benefit. And actually, we're better off not getting intervention, in that trial than leaving it alone, than having anything done. And why, I don't know, except that the TICI 2B3 revascularization was only 27%, in that trial. So only 1 out of 4 got better than 50% revascularization. So if you don't reopen it, you're not going to save anything, so I think that's one of the bigger issues. So, and I think this highlights it from IMS3, and this was kind of buried in the text of the publication and not really highlighted. But look at the 0 versus 1, 2A, B, and 3 in TICIs. Percent of TICI 0, 17.3, 9.1, et cetera. So the vast majority were, TICI 2A, less than 50%. Now, if you look at the outcome based on TICI grade, TICI 2B, 47.9, if you got them completely reopened, they did pretty good. Obviously you didn't do it very often. You only had 7 patients, right? So, I think, so I think this is one of the big areas that, all of the trials that have been published by the, and then we're finishing up there, are really not, designed to look at TICI revascularization. So, so for the future, what's next? I think better tools, maybe, right? Stent retrievers, new innovations, more trials, IV drugs, more, later, I don't know. Better selection, imaging, age, comorbidities, faster therapy, better systems of care, more resources, novel strategies, collateral augmentation, ultrasound, neuroprotection, interventional physiology, public education, get there faster, too late, too bad, I don't know. I think these are the questions. I think it's an exciting time. I mean, I think we're starting to ask some of the questions, and I think that's kind of hopefully where we're going to go, is looking for some of those answers. Thank you.